So may I have attention, esteemed faculty and delegates. I would like to take a few moments of your time to introduce myself and the distinguished faculty members of the session. Good afternoon and a warm welcome to all the dignitaries present here. I am Shweta from Learnet, serving as the allocated session assistant to ensure a seamless experience. Learnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Learnet serves as a digital partner for this event hosted by Indian Society for Assisted Reproduction, Karnataka. And the focus of today's session is on role of age in poor responders. So without taking any further time, I would like to hand over the session to Dr. Ashwini ma'am. Over to you, ma'am. Kindly proceed.
Thank you, Shweta. At the outset, I would like to welcome all the attendees here. I would like to welcome Dr. Devika, Dr. Jyoti, the seniors here. I would also like to welcome all our colleagues from KISAR who have joined here, members of KISAR. Thank you so much for joining for an interactive scientific session. So we all know that today we are discussing and from Gunashila Hospital, we are having a presentation on PGT-M. To give a little prologue about pre-implantation genetic testing, we all know that this used to be called as PGS very long ago, and the terminology has been changed now to depending on for what reason we do this test. For example, checking for aneuploidy is called as PGTA, that is pre-implantation genetic testing for aneuploidy. PGTM is for testing for a particular mutation, especially heritable diseases. And PGTSR is wherein we are checking for structural rearrangements in the chromosomes. We would love to hear a presentation of a case series of PGTM, which is not very common process across centers. Particularly from Gunashila, we have had quite a bit of cases, and requested Dr. Devika to share her experience and the team from Gunashila to share their experience on this particular testing and treatment for making sure that genetic diseases are not passed on to future generations. I welcome Dr. Ashwini M. Do we have a CV to display? Dr. Ashwini, can you share your screen?
Yeah.
Okay, I have a PPT with me. Okay. By any chance, can it be displayed, Dr. Ashwini?
Ma'am, I have sent it to you only.
Okay. Dr. Ashwini M is an MS and fellowship in reproductive medicine. She's a senior consultant at Gunashila Hospital in infertility and also high risk obstetrics and gynecology. Her affiliation is obviously with Gunashila Surgical and Maternity Hospital, Bangalore. Her areas of interest are infertility, recurrent implantation failure, high risk obstetrics, fertility preservation, and third party reproduction. She is a course coordinator for Rajiv Gandhi University of Health Sciences Fellowship in Reproductive Medicine. She's been part of several published and published several papers in national and international journals. And today she'll be moderating a presentation by Dr. Tanu, also from Gunashila. Welcome, both of you. You can take over from here.
Good afternoon, everyone. I am Dr. Ashwini M, Senior Consultant at Gunashila Surgical and Maternity Hospital. I would like to thank the entire organizing committee of KISAR and Dr. Devika ma'am for giving us an opportunity to present this journal club. With me, I have Dr. Tanu, who's my colleague, consultant at Gunashila and Surgical Maternity Hospital. Today, we'll be discussing a journal club on pre-implantation genetic testing for monogenic diseases, which is a Brazilian IVF-centered experience, which my colleague Dr. Tanu will be taking us through. Followed by, we'll also present our own experience with PGT-M. And later, I will explain each case in detail, how every case in detail. So without wasting time, I would like to start the session. Over to you, Dr. Tanu.
Good afternoon, everyone. So today we'll be discussing regarding PGT-M, pre-implantation genetic testing for monogenic diseases, a Brazilian IVF center experience, published in journal JBRA in year 2019, volume 23. As we all know, PGT-M uses embryo biopsy to detect genetic traits, that is autosomal recessive, dominant and X-linked disorder, allowing the selection and transfer of embryos without transferring the genetic diseases. Most of the couples who need PGTM, they are fertile, but they may have an affected partner, may have known history of family member affected, or may have already an affected child with any disorder. The first case reported for PGTM was a specific Y chromosome sequence. In this case, it was done by Handyside et al. In 1990, but they finally transferred embryos with XX sex chromosomes that nullifies the chances of having an affected male offspring. But the first true PGTM, it was done in 1995 for Tay-Sachs disease, which was an autosomal recessive inheritance. So most prevalent time for biopsy at that time from 2011 to 16 was cleavage stage biopsy, and the prevalence of trophoectoderm biopsy increased in the subsequent reports because of the excellent survival rate of the extended embryo culture and blastocyst vitrification, which gives more time of embryo diagnosis. It usually obtains between 5 to 10 cells, allowing more reliable diagnosis than 1 to 2 cells, which we usually obtain in cleavage stage embryo biopsy. So they have compared their data with the ESHRE PGT consortium 14 and 15. The PGT consortium ESHRE established in 1997. They discussed regarding the global trends and development in PGT from 1997 each year, and they compared their data with the previous year. However, it's been collecting the data from the European countries only, and up to date 20 data sets and an overview of the first 10 years they have been published. But in this case, the Brazilian Center, they have compared their data with the PGT Consortium 14 and 15, which was published in 2017 and represent the global outcome of PGT cycles performed in 2011 and 12. And according to this data, most common disorder that was diagnosed was Duchenne muscular dystrophy, Becker muscular dystrophy, Fragile X syndrome, hemophilia, cystic fibrosis, thalassemia, sickle cell anemia, spinal muscular atrophy, myogenic dystrophy, and Huntington's disease. However, this incidence, it varies according to the geographical conditions as well as the ethnicity of the population. The aim of this study was to describe the cases of PGTM in fertile couples who had undergone ICSI cycles in Brazilian IVF Center, and they determined whether these cases were different from those reported in ESHRE PGT Consortium Collection 14 and 15. This is a retrospective study from time frame from January 2011 to 2016 at a private university affiliated IVF center in Brazil. The total ICSI cycles they performed during this time frame was 5,070, out of which 72 cycles were of PGTM. They studied patient history, PGTM indication, ICSI outcomes, and PGTM analysis and results, as well as implantation, pregnancy, and miscarriage rates. The controlled ovarian stimulation protocol they used were a flexible antagonist protocol. The monitoring they did for with TVS follicular scan and serum E2 levels. The trigger they used was recombinant HCG, and ovum pickup was scheduled at 35 hours after the trigger. Then the retrieved oocyte maintained in culture media supplemented with 10% of protein supplement, and they removed the cumulus cell with chemical and mechanical methods. Oocytes that released the first polar body was considered mature and usable for ICSI, and approximately 16 hours after the ICSI, the fertilization was confirmed. Now the biopsy stage they used were 2 stages, cleavage stage and trophoectoderm stage. The most, because this study was from 2011 to 16, so the most common method they use is cleavage stage biopsy. On day 3 of development of each embryo is placed in 20 microliter drop of calcium magnesium free medium covered with paraffin oil, and the microtool fixed and aligned on inverted microscope equipped with Hoffman modulation contrast, and biopsy was performed with Octex laser shots. After the zona pellucida opened, a single blastomere was aspirated gently and removed from the embryo. In 10% of cases, they performed blastocyst biopsy also. Only the blastocyst that has good inner cell mass and trophoectoderm were biopsied on day 6, 5, 6, or 7 of the development according to the expansion grade. The hatching of the zona pellucida and trophoectoderm was disposed at 3 o'clock position, and gentle suction was applied to the blastocyst via holding pipettes, and laser pulses were used to cut the trophoectoderm. Now, the embryo diagnosis was performed by PCR in Associated Genetic Laboratory according to the established methodology, and the genetic screening for mutation identification was made first in the parents and or related family members, and then specific primers were designed for PCR amplification of defined regions of embryo genome. Endometrial preparation, they do it in a regular way. They use 200 micrograms of transdermal 17 beta estradiol every 3 days up to 14 days. And then they call the patient for scan and for endometrial thickness. When the endometrial thickness is more than 7.5, they started 800 milligrams of progesterone. If the beta HCG report is negative, they stopped both the estradiol as well as progesterone. If it is positive, they continued estradiol as well as the progesterone till 6 to 12 weeks of the gestation. All the women with a positive pregnancy test, they had transvaginal ultrasonography scan after 2 weeks, and the clinical pregnancy was considered when fetal heartbeat was seen. The implantation rate was defined as the number of fetal sacs per number of embryos transferred, and the pregnancy rate was measured per embryo transferred. And the miscarriage was defined as pregnancy loss before 20 weeks. The clinical outcomes of PGTM cycles compared to Esri PGT Consortium collection and ICSI cycles without PGT in their center, which includes all the cases of PGTM and pre-implantation genetic testing for aneuploidy. The results was expressed at percentage, p-values, and alpha adopted was 5%. The analysis were performed by SPSS Statistics 21. Now their PGT-M cycle results. During the time period 2011 to 16, the total ICSI cycles done at Brazilian IVF Center was 5,070, out of which 528 was PGT. That includes PGT-A and PGT-M. The PGT-M cycles was 72 out of this 5,070, which concludes 13.6% of total PGT cycles and 1.4% of total cycles performed. And the total number of embryos they biopsied for monogenic diseases were 434, which is 16.7% of all the embryos biopsied for PGT, including A, M, and SR, and 1.5% of the total ICSI embryos obtained during these 6 years. The general characteristics of the patients undergone PGTM cycles were maternal mean age was 32.34%, paternal age was 34.47. The total oocytes obtained 11.65, M2 oocytes 8.71, fertilization rate was 84.65, and obtained embryo, the mean was 7.28. The most common biopsy they have done for these cycles was cleavage stage biopsy, which was done for 90.3% of embryos, and the successfully biopsied embryo were 93. The genetically 93%. The genetically transferable embryos were 59.4%. Out of these, normal embryos were 22.5%, carrier embryos were 36.9%, and affected embryos were 40.6%. Out of 72 patients, 49 patients had an embryo to transfer after PGTM results, and their cancellation rate was 32%. 17 out of 77 patients had implantation rate was 22.1%, pregnancy rate was 28.6%, and miscarriage rate was 7.1%. And their live birth rate was 26.5%. They compared their data with the PGT Consortium 14 and 15. When they compared, the cancellation rate was more in the Brazilian study as compared to the Esri PGT Consortium. However, the implantation rate, pregnancy rate, miscarriage rate was similar. The indications for the PGTM cycle in this Brazilian study was sickle cell anemia most common, followed by thalassemia, followed by spinocerebellar ataxia, followed by Fragile X syndrome, followed by severe combined immunodeficiency. Now we'll discuss the PGTM cycle data and their result at our center. We have started our PGTM first cycle in the year 2019. So the duration of study is 2019 to 2023. The total number of ICSI cycles were 2064. Out of these, 310 was PGT cycles, including A, M, and SR. Total number of patients screened for monogenic disease were 32. Out of these, autosomal dominant was 6, X-linked recessive was 2, autosomal recessive was 22, and 2 of the patients have combined disorders. Although 32 patients come for screening of this monogenic disease, only 14 patients out of these 32 have agreed for PGTM cycles, which constitutes 4.51% of total number of PGT cycles and 0.67% of total number of cycles performed for ICSI. Now, the general characteristics of PGTM cycles at our center: the mean maternal age was 31.31%, paternal age 36.46%. Number of follicles obtained per cycle 17.5%, M2 10.5%, fertilized follicles obtained 17.5, M2 oocytes 10.5, fertilized oocytes 8.69, and obtained blastocysts were 6.77. The most common type of biopsy, that is 100% we did for blastocyst trophectoderm biopsy on day 5, day 6. The total number of embryos biopsied for monogenic diseases were 69. Successfully biopsied embryos were 100%, that is 69 out of 69. Genetically transferable diseases, genetically transferable embryos, that includes normal or carrier, were 39.1%, and normal embryo after PGT-A and PGT-M, out of these 27 was 17, which constitutes 63%. The carrier embryos out of the 27 genetically transferable embryos were 10, which constitute 37.01%, and affected embryos were 42 out of the total embryos screened for PGTM, which was 69. Now, out of 14 patients, 13 patients has an embryo to transfer after PGT-A and PGT-M results. The cancellation rate was 1 out of 14 patients, that is 7%. The number of patients that underwent FET out of 13 patients were 10. Remaining 2 are awaiting frozen embryo transfer and 1 is awaiting surrogacy. The implantation rate was 71.4%. The pregnancy rate per embryo transfer was 90%. Miscarriage rate was 30%. And the live birth rate was 60%. Now we compared our data with the Brazilian study. The number of embryos biopsied and the diagnosis was 100% because of the trophectoderm biopsy. The genetically transferable embryo we compared, it was 39.13% at our center, and compared to the Brazilian study, 22.5%. Our implantation rate is 71.4% compared to theirs, 22.1%. The pregnancy rate was 90% as compared to 28.6%. The miscarriage rate is 30%, and the live birth rate is 60% as compared to them, which was 26.5%. Now, Dr. Ashwini will describe the all the patients' summary, which have undergone PGTM cycles.
We have had about 14 cases. Out of 32 screened, only 14 patients were willing to undergo the PGTM. So to begin with, patient A, here the patient herself is affected with chorioatheroid movements. They have a consanguineous marriage where she's married her cousin. She's homozygous and affected with glutaric acid urea type 1, which is autosomal recessive condition, and her husband is heterozygous. So she's underwent PGTM. She has 3 carrier embryos, and all those 3 carrier embryos are PGT-A normal. She is awaiting her frozen embryo transfer in the next month. Patient B came to us with a history of she had a child which was affected with polycystic kidney disease and the baby expired. They also have a consanguineous marriage where both wife and husband are heterozygous for polycystic kidney disease 4 with or without polycystic liver disease, and it is an autosomal recessive condition. This patient produced about 4 embryos, of which 2 were affected with PGTM and were normal on PGT-A. And the rest 2 one had trisomy 1 and the other one had multiple aneuploidy. So she didn't have any normal embryo, hence we had to cancel the cycle. Patient C came with a history that she had a brother who was diagnosed with DMD who's expired. And on screening, she was a heterozygous, and she was carrying this X-linked recessive DMD gene, a gene for DMD. Husband was normal. So she underwent PGTM with and PGTA with us. So she had only one embryo, which was normal, but it had mosaic monosomy 16 and 25% only. So we went ahead and transferred this. At around 9 to 10 weeks of gestation, she had a spontaneous miscarriage. Patient D came to us with a history of previous child having benign myokemia of infancy, that is weakness of lower limbs. And here also both the couple were, I mean, they had a consanguineous marriage. The wife was homozygous and husband was heterozygous. They had two genes which were affected, and the gene was like resulting in development and epileptic encephalopathy too. Likely to be benign. So when they underwent PGT-M and PGT-A, they got 3 embryos, of which we counseled them to transfer 1, but they wanted to transfer 2 embryos. So we did transfer 2 embryos, and she has delivered, and she has a healthy male child who's been screened after birth and is negative for the disease. Then patient E came with a history that she had a previous pregnancy and where she has delivered a child which was affected with a West syndrome. Here also they have had a consanguineous marriage where the cousins have been married, and both are heterozygous for glycine encephalopathy, which is an autosomal recessive condition. This patient produced plenty of oocytes, but ultimately had one embryo, which we sent for PGTM, which was normal, which was PGTA also normal. So we transferred that single embryo, and she's delivered a healthy baby. Then patient F came with a history of previous child which had congenital heart disease and ASD secondum. And both of them again had a consanguineous marriage, and they were heterozygous carriers for WASH C5 gene, which is autosomal recessive condition resulting in Richter-Schisnell syndrome 1. And they have on PGT-M, they have 2 embryos which were heterozygous, that is carriers, and PGTA normal. She wanted us to transfer both the embryos, and she's delivered a single live baby, which is healthy. Then patient G came to us with a history of previous 3 children who have been affected with hereditary spastic paraplegia. This is also a consanguineous marriage where both husband and wife are heterozygous for this autosomal recessive condition of spastic paraplegia. They have undergone, they have completed their PGTA cycle where they have got 3+1, that is 3 PGTM normal and 1 carrier embryo, which are all 4 are PGTA normal, but they are awaiting their frozen embryo transfer. They want to come back after 2 months. And H is a patient where husband is affected with Apert syndrome, which is autosomal dominant condition. She had plenty of embryos, but finally she had only one normal embryo, which was both PGTM and PGTA normal. We transferred, and she spontaneously miscarried around 8 weeks of gestation. Then we had a patient where here the patient herself is affected with the history of epilepsy. She's mentally challenged, and she has gait problems. She is a heterozygous carrier for an autosomal dominant gene, which results in epileptic encephalopathy 14. And she has one PGTM and PGTA normal. Because of her condition, she is awaiting surrogacy. Patient J is where they came with history of previous one child which had convulsions and developmental delay. Here, husband is heterozygous for an autosomal dominant condition, that is developmental and epileptic encephalopathy 7 and myopia 24. They underwent PGTM and PGTA. They had 2 embryos, and we counsel all patients for single embryo transfer because they are fertile. But now, when patient insists, we don't have any other option, so we have to transfer. We had to transfer both the embryos. She is delivered twins. and both the babies are healthy. Then we have a patient by name K. This patient is very interesting. She is a very well-educated lady who came with knowing that she is a carrier for beta thalassemia gene, and she's been married to a husband. She got her husband screened, so both of them were aware that they are both are heterozygous carriers for beta globulin, the autosomal recessive condition. So they underwent PGTM and PGTA. They had 2 embryos which were normal and 2 embryos which were carrier. So she has transferred 1 embryo and delivered a healthy female baby. This was in fact our first PGTM case when we started. Then patient L has a previous child which has a weakness of both the lower limbs. Wife is heterozygous for DMD, X-linked recessive condition, that is Duchenne muscular dystrophy. This patient had 2 normal embryos. She underwent 2 frozen embryo transfers with us, but she failed. I would like to stress this patient, apart from having this PGD, she also has history of recurrent implantation failure. About 10 embryo transfers she had failed prior to coming to us. So then another patient by M who came with previous she is a patient who had previous 2 pregnancies which were terminated because on ultrasound they are diagnosed that the babies have skeletal dysplasia. So when they screened, they had a consanguineous marriage. Both are cousins who have been married. Both were carriers, heterozygous and carriers for the skeletal dysplasia gene. And in fact, she had 2 normal embryos. One we have transferred. One is still there with us, and she delivered a healthy male baby. And patient N had came to us with a history of like a previous child with muscle weakness. This is an interesting case because both husband and wife are carriers for multiple genes here. And those genes are associated with glycogen storage disease 7, Fanconi, Reno tubular syndrome 4, myopathy, and myofibrillar 6. So because they had so many genes, that's a combination of recessive and dominant, we could get only 2 carriers of them, wherein we transferred 1 embryo. She got pregnant and she miscarried around 9 weeks. But later, after 6 months of miscarriage, she developed a full-blown SLE. And now she's having another carrier embryo, and she's wanting to go ahead with surrogacy. Over to you, Tanu.
So the incidence of autosomal recessive dominant and X-linked is 19%, 64%, and 18% respectively in the patients requiring PGTM globally, according to the ESHRE PGT Consortium Data Collection 21, which was published in 2023. So it is important to screen the couples with history of affected family members, affected offspring, and affected partner. Hence, genetic history is of utmost importance in the couples coming to us. The PGTM can elevate the emotional and psychological burden of worrying about passing on a genetic condition to the future generations and ultimately lead to the birth of healthy children. It is important to club PGTA in the couples undergoing PGTM, irrespective of maternal age, to avoid the transfer of aneuploid embryos, which could be PGTM normal, as our ultimate goal is to deliver healthy genetically normal offspring. Of 32 couples screened, only 14 couples underwent PGTM due to the financial reasons, as it involves the cost of IVF, PGTA, and PGTM. All the couples have to offer prenatal invasive testing after the transfer of PGTM normal embryo. But at our center, all refused and were confident with NIPT only. Post-delivery, couple were again advised to repeat the genetic analysis. 3 out of 6 couples only agreed and confirmed no disease transmission status, but others refused as they were too scared of the results and don't want to know the status. However, the babies are clinically normal.
Thank you.
Thank you so much, Dr. Ashwini and Dr. Tanu. That was fantastic. It was quite inspiring and stimulating the brain in all directions. Just one question. I see that the miscarriage rate was slightly high. Any reasons that we can give for that? Dr. Ashwini?
They are fertile. She had no significance, but later we found out too that she
Ashwini, I
had,
think the whole conversation was cut. Just now you became audible. Can you just repeat?
Yeah. Of the 3 cases who aborted, one patient we had transferred a mosaic monosomy 1 embryo. That is because she didn't have any other embryo which was both.
AMD.
Yeah. So we had to go ahead and transfer that. That could be the cause. And the second patient, like I told you, she was a mother of 2 kids who have already affected, and we didn't screen for anything else because they're very fertile. So we went ahead, she miscarried, but later we found out that she had SLE 6 months later. So that could be the cause.
Possibly because all of them seem to be having already a pre-existent,
Yeah, upward
very untreatable confounding problems.
Can I
I
come?
have,
Can I?
can I ask one question?
Yeah. I just want to talk about Ashwini's pregnancy loss. Now, doing a PGTM and doing a PGTA doesn't guarantee them a pregnancy. So at the most, if they do get pregnant, then the future generation is free of the disease, which is what we are aiming for. But then if they have a miscarriage is again related to so many other problems.
Yeah. Ma'am, they say that if we do a PGTA, the miscarriage rate comes down to less than 5%. But possibly these women had other autoimmune diseases or something, is what I'm assuming.
Yeah, might have, but I don't think that with a PGTA, transferring a PGTA is going to reduce your miscarriage to less than 5%. The thing is that doing a PGTA will decrease your time to pregnancy, and also will decrease the number of attempts, especially in a recurrent implantation failure. It will decrease the number of attempts that is required to achieve that pregnancy.
If I can offhand, if you can remember, what's the miscarriage rate only in PGTA, ma'am?
If you take a cumulative, like, there was one article by this Paul Pertia, and if you take he looked at the cumulative pregnancy rate, and that went up to almost 95% with a live birth rate of something like 92%.
Yeah.
But that was
You guys had presented that in the last journal club.
Yeah, that was a cumulative pregnancy rate over 3 transfers.
And miscarriage, ma'am? Any miscarriage?
Around 3 to 5%.
Yeah, I'm not too sure about what exactly it was, but their live birth rate was
In your experience, ma'am, at Gunshila, what is the miscarriage rate for PGTA?
That is something that I have to calculate and let you know.
Maybe
give you a
next time. Sure, no problem. Thank you, ma'am. Dr. Santosh had something to
Yes, Tosh.
Good afternoon, ma'am. It was a wonderful presentation and work as well. I have one basic query that your study was a trophoectoderm biopsy study, and and why you have chosen to compare it with a cleavage stage?
Yeah, you shouldn't have come.
Because we thought that was an interesting study. That was the only thing. There's not been much in the literature.
There were so many differences, is what I felt, ma'am, between the two studies.
Yeah, 90% of the embryos were done in cleavage stage, but then what they did
They
was
have also transferred blastocyst only.
they've done
They
an
haven't-
embryo at cleavage stage. So they've taken a single blastomere, they've analyzed it, and then they have grown it, they've frozen it and grown it again till blastocyst and put in a blastocyst embryo. That is in the article. And there are very few articles that have come out with, apart from the PGD consortium, X-ray consortium that has come out, which talks about just the global phenomenon and what is the most prevalent diseases and blah, blah in the European population. We thought that this was one of the articles that was closest to us. That's all.
Even
I think
really there is not that much of a comparison
No,
because
actually,
they have done
yeah,
400 and something
21.
cases, and we've done some very few. So the
percentage
numbers also don't
yeah.
match. But that is just an interesting study to talk about.
But that's big data, ma'am, I suppose. It's almost
164, yeah, it's a huge data.
Yeah, it is big.
Exactly. So we can't kind of draw. I'm trying to say we can't draw comparisons between a study that has 464 patients over 6 years and our study, which has how many patients we did?
We had 72. Sorry,
how
we
many
had
patients?
14 cases,
14
69
cases.
embryos.
Yeah, 14 cases, 69 embryos.
They had 72 cases. Embryos
Yeah.
were 400 and change.
Yeah.
And the recent X-ray PGT consortium results also I have, but I haven't put up because they only express the percentage. They have not quoted anything like what was their actual numbers. So according to that, their pregnancy rate is 41%, their clinical pregnancy rate is 32%, and live birth is 36%. This is recent 2023.
So
have done.
there is a miscarriage that happens. People do miscarry, but miscarriage happens for so many reasons, which includes the uterus as well as the receptor status and also the signaling and alloimmune causes, all of which we are not looking into when we do PGTA or PGTM, because we suspect that they are fertile people. They have had babies, unfortunately, who have died or whatever because of problems, genetic problems. But miscarriage wouldn't come into that whole scenario. That's number one. Our pregnancy rates, our live birth rates are 60%, but obviously I'm sure that if you have more numbers, that's going to fall as well. Yeah.
Yes, ma'am. But I'm not sure. I'm aware of centers, at least in South India, that are doing more than these numbers, especially PGTM. Anybody knows the data of PGTM?
See, the thing is, the number of
It's already a bigger data is what I mean, ma'am. I mean, we are lucky to even go through this.
Oh, you're saying that our data is the big data,
So,
no?
yeah.
Yes, ma'am, it's a big
I-
data.
Yeah, we.
Total, we have spoken to 32 patients who will have counseling with us, and then they'll have counseling from the geneticist also. We have Dr. Swati ma'am here with us, and there is one doctor called S.J. Patel. Despite of counseling, you know what happens? Finally, only 14 turned up because there is a lot of
The
cost.
financial constraints, yeah.
Financial
So
constraints,
many things.
because they have to pay for their IVF, they have to pay for PGTM, then they have to pay for PGTA.
And you know what? When you do a PGTM, you want more embryos, you want more oocytes, because you want them to translate into getting more embryos. So, because if you can see, people have like our first case, which is a PGTM for sickle cell disease, she had 13 embryos, out of which only one was normal. This is a lady from Mysore, and it was only one was normal, and we just put that, and by God's grace, she got pregnant. That's all.
She was a very clever lady who knew.
No,
We escaped
I
further
have done,
counseling.
ma'am, one case, 4 cycles, no normal embryo, 4 cycles, no normal embryo. Both husband, wife has some.
Yeah,
So
one
they
patient,
would have spent a bomb. So
Yeah,
it's an expensive thing.
exactly.
that patient too, which I told, she had like, you know, 2 embryos which were affected with PGTM. They were normal on PGTA. She had 2 embryos which were PGTM normal, but they were PGTA abnormal. So
So you have all
finally,
sorts of
it's a
combinations.
combination.
Yeah.
And you know, one cycle will not guarantee that they will get a genetically normal embryo. That is also there. And what happens, other couples who are having an affected child, no, for them to manage that child at home and then come to us for treatment also, they'll be thinking a lot. Because
We've
And if
had
the
parents,
AMH is low, it's a double whammy, I suppose.
and we've had
they'll
parents
also have to
actually
spend
carrying the child and coming.
they'll also have to spend
8-year-old child, 10-year-old child who cannot walk, bringing them every time because there's no caretaker at home. It's a very difficult situation in our country. I'm sure in the West there's plenty of social service and all that kind of a thing happening. The government looks after these kind of parents, but I mean children. But then in our country, it is very sad and it's very difficult.
and they have to also,
And unfortunately, we can't guarantee them a pregnancy. That
is
is our karma.
All doctors, ma'am. Nobody can
I
guarantee.
have something to add here.
Yeah.
I have something to add here. Good afternoon, ma'am. I mean, congratulations. You're doing
Anyway,
such great
Good
work.
afternoon, Nivedita. Thank you.
I'm glad that we could, we can actually access so much of information, know that you're doing such good work. What I wanted to add here is that what I gather, Kraft Hospital and Dr. Ashraf, I think he does a bit of good work. He also does good work. I'm sure his data also must be comparable. That's the only thing I
I don't
remember.
know if they have published, but then we could not find anything. There has
ma'am,
been.
if I can have a question for the geneticist also.
Yeah,
Dr. Swati, is it?
Is she
My
there?
question is, between a third day embryo biopsy wherein only one cell is aspirated versus a 5th day wherein you're aiming for 5 to 6 cells of tissue for testing. I can't say tissue cells for testing. Can you just elaborate on what would be the intricacies, or is the accuracy same, or it drops down drastically for a third day biopsy?
So we've always worked with the, 5 and 6 day biopsy. Initially, when we standardized it itself, we realized that the amount of DNA, first of all, that you get will be more, which is important. And because you're getting a few more cells, even though it's like 1 or 2 more cells. Also, when we talk about PGTA, and there is this mosaicism which we can detect, right? So that becomes slightly more accurate to predict when we have a few more cells. So it's a little more uncertain when you have very few cells and you're doing your experiment based on just and giving an a picture based only on that. So yeah, right now I think all the guidelines say to do day 5, day 6. Yeah, so we just go with that.
One more thing I want to add. When it is in a 3 cells, when it is a day 3 embryo, you have very few blastomeres. As it becomes day 4, the cells divide very, very, very rapidly. And so it's more prone to mitotic errors. So if you only take one cell, it may not really be a reflection of the whole embryo. Even doing a trophectoderm biopsy, and that is why there is so much controversy regarding PGTA. So even doing, when you do a day 5 or day 6, and we try to get 5 to 8 cells, and that gives them enough of, gives the geneticists enough of DNA. And in spite of that, sometimes we get insufficient DNA as one of our reports. But the thing is that, so when you get more cells, it is more likely to reflect the inner cell mass, number one. Number two is that it has been shown historically and otherwise as well that when you do a day 3 biopsy, your pregnancy rates come down. It can be either for PGTA or for PGTM or for whatever, but if you do a day 3 biopsy embryo,
the bulk of cells possibly comes down and results in a problem. Ma'am, one additional question, sorry. The NIPT, Ashwini also mentioned about doing an NIPT.
No. NIPT we do for all PGTA cycles. We do NIPT. We do screen again later to make sure it is okay.
For aneuploidy, are you able to even figure out mutation?
For aneuploidy, they didn't want to know the status at all, ma'am. They don't want to know. We have to, like,
Is it possible?
No.
Dr. Swati, is it possible that if you know much ahead about the mutation, will you be able to check for that in the DNA of the mother? I mean, the blood sample of them.
Swati, you're muted.
Ma'am, you're muted. Swati, ma'am, you're muted.
Oh, sorry. Yeah, no, that won't be possible. First of all, because DNA is also very fragmented and we're looking for, quite a bit. And it's also not recommended.
Okay. What about in the far future?
Maybe. Maybe. I mean,
so similarly, is it possible that the spent media will eventually help us for PGTM? Now, non-invasive PGTA has come up, right? Similarly, is it possible that it will be refined to become a non-invasive PGTM?
It may become, but right now we have experimented doing just PGTA, not even PGTM with spent media. And we've also looked at, subsequently with the biopsy results and stuff. And the correlation is not good at all. And we did this in conjunction with one of the people who makes these kits. And they had various centers also try it to figure out whether this is a viable, useful, and whether there is correlation. But throughout in all the centers, they found that it's not a correlation. So right now, this is only for PGTA. We haven't even gone up to the PGTM stage. But right now, no, it's not. Though some people are saying they're doing it, guidelines also say
and
it should
be spent
are high, media. Actually. Yeah, absolutely.
Nivedita, you have me on a debate for this non-invasive PGTA versus invasive PGTA, okay?
Ma'am, you want the non-invasive or the invasive? For or against?
Whom you want to debate with? That was my question, ma'am.
I don't mind anybody.
Somebody who's strong enough to stand against that. Ma'am, you're against NIPGTA is what you mean?
I am against non-invasive PGTA because it has not been proven. And I actually had a chat with these. I do not know if I should be saying this. You please tell me if I'm going off the radar, which quite often I do. But then I had a chat with the iGenomics guys when they came to me. And I told them, I mean, he was very nice, etc., etc. We were discussing so many of my other problems that, etc. So it's because they've taken distributorship of some other company and some nonsense. But anyway, so he said, I told him that you're promoting PGT, non-invasive PGT in a big way, and you're misleading people. And it's not to be done because the what is your concordance rate? I asked him. He said it's about 70%. 70% is not a good enough concordance rate. I think Dr. Swati should be able to tell us what is the concordance between, or Sachin might tell us what is the concordance between our, we did trophectoderm biopsies and biopsies of inner cell mass. And we also looked at trophectoderm biopsies with the blastocele fluid. And our concordance rate was quite high. It was somewhere in the 90%. That is, you can't get 100% concordance because these cells are multiplying so fast. So that is why we get mosaicism. But the thing is that you can't say, okay, my concordance rate is 70%, so I'm going to be fine with promoting the test. So I actually had an argument with him. And I said, what you're doing is very wrong, because you're telling all the youngsters who may not know, the exact scenario, and you're telling them that you'll go ahead and do a non-invasive NIPT. And there was an IVF center in Australia where they got sued right, left, and center because NIPT non-invasive at that point, what's that called? PGTA non-invasive at that point of time was not proven to be as good as invasive PGTA. Even now, invasive PGTA is not that good. And that's why you have this huge debate that is going on.
I have a question here, ma'am. So possibly it is not 100% thing, may not be a diagnostic test, but can it be or become a screening tool for selection of embryos?
How will you select embryos? I think Swati should answer that. How will you select embryos and what kind of a screening tool would you want? So you're going to tell a patient that you're going to be spending so much of money because PGTA, and trust me, if I knew genetics was so expensive, I've told this to Dr. Swati also, who's our scientific director, I would have never started a genetic lab. Okay, but the thing is that you can't tell a patient that, hello, I'm going to do this extremely expensive test, but then it's only 70% accurate.
Yeah.
It's not acceptable. What do you think, Swati?
Yeah, no, I mean, I guess you could give that as an
I-
option to the patient, saying we only have 70% accuracy. There is this 30% chance that we could be wrong. And if they're still,
See, among the confused
accepting.
lot, yeah, my suggestion is that if we have like 8 to 10 embryos, having all good more than say 5 or 6 blastocysts, if there is some way of saying which chromosome seems to make sense rather than totally normal, to just select the best so that you can reduce the time to pregnancy, you choose them for transfer first. Doesn't necessarily mean that you're labeling that abnormal as abnormal or normal as normal. They still need further testing later.
As long as, so what further testing you want to do then after that?
It remains the same. For as any other pregnancy, how you check for aneuploidy in pregnancy, you have to live up to those testing, and you have to make sure that you do that. But this is only to reduce the time to pregnancy, so that if we have surplus embryos, this test will it help us in selecting the best among the lot?
You're talking about with the spent media.
PGTA, yes.
Yeah, but the cost remains exactly the same as doing a PGTA,
Cost is more,
right?
yeah.
It's just that your biopsy, you're just not doing, only that is expelled, but the actual cost of getting your results,
It remains the same,
you're doing the
yes.
same thing.
So there are times, Dr. Swati, that people don't mind the finances. If there is a test that can give some idea as to which has to some extent a normal chromosome, and if we are able to choose them for transfer first, is it a logical thinking? Is my question.
I mean, if you can't do a biopsy, then you don't have access to a biopsy, then I would say yes. And given, after having explaining to the patient that these are the odds
And cons,
of it
yes.
being all right.
Yes.
Yeah.
Can be considered.
As long as the patient knows that he's spending a bomb
Good.
on a test, which is only going to give him some amount of
It's a
information.
screening tool, ma'am. Not a diagnostic tool, as a screening tool. If you have surplus embryos, if you want to choose that.
I have a question,
Yeah.
Dr. Devika. Where do we stand medico-legally after doing all these things? Screening, testing, whatever. Supposing the patient we transfer and she does develop some problems. How safe are we medico-legally?
What kind of problems are you talking about? Now, see, medico-legally means we're not telling them the sex. I'm just talking about general now PGTA, right? This is not talking about
No, sex determination is not allowed. That's
Correct.
out of the radar.
Yeah. So you're not telling them the sex
Maybe
is the
what she means, ma'am, is
What
that
I mean is that, say, supposing, do you transfer mosaic embryos?
yes, we
Yes,
transfer.
And if you don't, yeah, that's where my question lies.
what is
Say
the
we transfer a
duration?
mosaic and we end up with some,
we do prenatal.
problem. Where are we medico-legally? This is my question only with mosaic. The other embryos I know where there is confirmation, we are going to discard those embryos. But in mosaic embryos, could you
Now,
please throw light?
yeah, the latest PGDIS guidelines, that is PGD International Society guidelines, says that you can actually go up to, correct me if I'm wrong, Swati, but you can go up to about 40 to 50% mosaicism. Okay, but we do not go that far. Dr. Swati will immediately put her foot down and say, don't put in the ones that are 40% mosaic. Okay.
Okay.
And there is a recent article which actually Dr. Swati knows about, and she sent it to me, where you can look at mosaic embryos and then it has a classification of what is the effect. Will these embryos survive? Will they become a live birth? Will it end in a miscarriage? If it becomes a live birth, what are the complications, etc., etc.? So there's a table and there's a scoring system. So if you have, shall we say, mosaic, I think trisomy 1, which is 25 to 30%, which is an acceptable mosaicism, the score for trisomy 1 is 0. That means she may not have a miscarriage. This baby might end up in a good live birth. They may not have any problems at all. And there is always a chance of autocorrection. So as long as you explain the whole thing to the patient and tell them that, look, I'm
Everything
putting
is
in a mosaic
documented.
embryo, but there is a chance of autocorrection. But if, and all the time when I'm trying to kind of tell patients that this is the only embryo you have a mosaic embryo, and I will actually Google it. I will show them what a trisomy 1 or a trisomy whatever 19 or a monosomy something looks like, and I will show them the pictures and say that, but this is only 25% of your cells have it. So really there is a chance of autocorrection. So you can transfer it and take it in writing that they understand that they can transfer it and still have an embryo that is not a baby that is not completely normal. Only then will we transfer it. And then they have to go through several rounds of counseling from me, from my senior consultants, like both the Ashwinis, and only then will we transfer it. Any take on that, Dr. Swati, about the mosaicism cutoff?
Yeah, like you explained, Dr. Devika, there are studies which have given a scoring saying which are likely either to autocorrect or they may undergo miscarriage if there's mosaicism. So you're safer to transfer those. Like 16, trisomy 16 has the highest score and it's not recommended at all. So that way, even if you have 20% mosaicism, we would say, please don't transfer that. So that's sort of helpful in transferring thing. And but in terms of medical, we can never be 100% sure that even if the child is born, they may not be something, because there are case reports where there is they have found mosaicism in children with certain defects or disorders that have come up. So that is something we cannot assure them, and that's why they take the undertaking and their consent that they understand.
They have to be absolutely sure that they know what they're getting into, because finally at the end of the day, after the baby is born, they can't disown the baby, or they can't say, listen, you came and you did this, you did that. So everything is documented and multiple times, and they have to sign also. And also, according to the PGDI society, if you have counseled them, and if you have given them all the facts, laid all the facts on the table, then you're okay to go ahead and do it.
Even for that matter, ma'am, euploid embryos also, when we transfer and send for PGS, there is a consent that being euploid doesn't mean 100% normal baby.
Correct.
So,
Yeah, exactly.
So there is always a thing, because human life is not so simple as it could be. So
yeah, exactly. Correct. Very good.
Thank you. Thank you, ma'am. Thank you all. I think
Thank
we
you
are
so much.
at the end of the session. It's 3:59. I thank the team from Gunashila Hospital, Dr. Devika, Dr. Ashwini, Dr. Tanu, for presenting their data. It was such an excellent knowledge sharing, I must say. I thank the President, who is here, Dr. Nivedita. Any comments? Thank you, Nivi. I thank all the EC and the faculty and the delegates who have attended today, who have contributed. Thank you, Dr. Swati. It was very nice having a chat with you. Thank you all. Our next session from KISAR would be on parvovirus. Possibly we'll be announcing the dates and the time in a couple of weeks.
It's
As we
7th
all
of June, 7th of June, role of LH in poor responders.
right. All right. The role of recombinant LH on only in poor responders. Okay, we'll come up with the title possibly in a week's time. Thank you, everybody. Have a fantastic rest of the day.
I want
See
to
you
say
soon.
something. I want to
Yes,
say
ma'am. Yeah, Doctor.
is doing a fabulous job with these sessions, and I have tried to attend a few of them. Few of them I missed. I wanted to attend the LIT session, but then I missed it. I mean, so that was something that was unfortunate. But for me, that is. But then thank you very much, Nivedita, Ashwini, everybody, all Santosh, everybody who was in
Thanks
the
a lot.
committee and the group and everything else. And we've had a wonderful time actually presenting this, as well as, you know, every time we do something, we do a talk, we go back and read and, you know, sharpen our own, polish our brains a little bit, and then come back to this. So thank you for the opportunity.
Absolutely, ma'am. Conducting these sessions, we are also learning a lot. Thanks to all of you. Thanks.
Thank you
Thanks so
so
much.
much.
Have a
Thank
great
you.
time.
Bye-bye.
Bye-bye.
Bye-bye. Bye.
Bye. Bye.
Thank
Thank
you
you.
everyone for giving us the opportunity to host this session. I hope you all had the same seamless experience with us. So are we good to conclude the session over here? Thank you so much.
Yes.
Thank you.